Welcome everyone. Here we are at this evening's Freedom Hub presentation of the free market cash patient world. I'm your host, Jeff Cantor, along with Charles Frohman, and we are being sponsored by your Freedom Hub. And of course, that's where all the activists and entrepreneurials tend to hang out and disrupt things for the better. And as I indicated, we are also recording these. So this is the link to go to register so you'll get notices as all the future ones occur. And otherwise, these are the 3 sites at the moment that we're posting these at, so whichever one you prefer. They're typically posted over the weekend, so come Monday they're on there. And just to kind of divert, this is the hub site. Here's like an example of what's up on the site for Brighteon. There's an awful lot on this one. It's one of the ones we've used the longest. There's BitChute as an example. So they're all out there. There's some great ones to watch on all of these instances, and tonight's going to be no exception. So what we're going to want to do tonight is now do a little intro as to who our guest is and kind of find out what's in store for us. Charles?
Thank you, Jeff, and welcome, Dave. We're very excited to have Mr. Racer present tonight. Jeff and I have known him fairly well over the past couple of years, as Jeff and I have disrupted the health payment world with our making of cash shopping patients. And one of our biggest groups in terms of liking what we're doing has been the Free Market Doctors Group, the AAPS, the Association of American Physicians and Surgeons. And they've been promoting this book, Common Sense Medicine, that was edited by Dave Racer. Dave has written and edited a lot of other books and manuals as the principal CEO at DGR Communications. His main book that he wants to talk about is Passion for Patients. And, you know, I think I met Dave, I'm not really sure how, back in, 10 years ago or so. And I got him on this this advisory board for Governor Gary Johnson's political nonprofit, Our America Initiative. And maybe I met him back in the 2000s when I was helping Greg Scanlon's Consumers for Healthcare Choices. But especially we know him through the Free Market Doctors groups. He definitely is known by them as a great author and communicator of free market ideas. And what particularly excites us about tonight is showing us his deck. He has an image of an intersection to really help us visualize comparison pricing for health procedures. And the gas station effect is the ideal that Jeff and I have for our cash patient world. The idea that like with a gas station, you can see these different prices close together, easily changeable, to really force useful signaling to get healthcare priced correctly. So that's our introduction, Jeff.
Wow, that sounds fabulous. Well, David, I'm going to give you the screen here, and let's see what you've got in store for us, like I said.
Well, let's see what I have in store for you. It's great to be with you all. We're going to do something a little bit different. Actually, I think this is the almost first time out of the chute on this. Charles had mentioned a couple of the books that we've done. Actually, I've done 20 books on healthcare now, and this is the 20th. Passion for Patients is probably my favorite book of all of them. We did that one with Dr. Lee Beecher 3 years ago. It's a great book. This little manual, I say little, it's 96 pages, is a 15-month project. It actually took longer to write this than Passion for Patients because it's so rich in data and ideas. It's a very unique kind of book. And we've delivered it all over Congress and into Minnesota legislature here, where we are trying to promote an idea. And this is what we're going to be doing. You know, guys, I have learned in writing all these books and talking all about healthcare that there is no single answer for anything. It's very complicated, and at best we can introduce new ideas that can serve to revolutionize the whole process over time when added to other things that we're working on. And so I'm not going to discuss things that necessarily are any different than what y'all are doing. I'm going to focus on one particular area tonight from the manual Healthcare 2020. What about healthcare? The reality is it's very expensive. And at $20,576 average family premium for employer-sponsored healthcare, it's unaffordable and getting worse. In Minnesota, in fact, we've seen premiums for family plans as high as $35,000 and $40,000 a year. That's absurd. It's insane. It can't go on. And yet it's getting more expensive. And our buyers are saying, I can't afford it now. What am I going to do in the future? And so we have to find a better way to do things. Now, we're talking about this gasoline idea. And so I thought, well, we'll use the current gasoline prices. Is this not fun today? And you could stand in an intersection and not get hit by a car because there's not very many on the streets at the moment. And you could look at the prices of the gas at the different stations, and you've all seen this on different corners. Generally, they have about the same price, but just a little bit different. Not that way with healthcare. How do we buy healthcare? Totally blind. We don't know the price. Here in Minnesota, we worked on a price transparency law. My partner, Greg DiTillo, and I wrote the first draft of the law, and we were able to get it through the legislature. It passed by huge margins. The lawmakers know that they have to have price transparency. So in Minnesota, you can get the billed price that nobody pays except people without insurance and don't know any better. You can get the average insurance reimbursement. You get the Medicare price, and you get the Medicaid price all together on a chart in the clinics that are required to post it. And we were really excited about that because it gave us a chance to finally see the prices that these clinics were charging, but we discovered it wasn't enough. You ask yourself, how can you have a marketplace for healthcare if you don't know the price? How can you shop without knowing the price? And you have to get the price. Even with Minnesota's transparency law, it's only the top 25 procedures in certain clinics. It's not the entire 9 yards of healthcare pricing. And even with the federal edicts on hospital pricing, it's so complicated, it's just about impossible to understand. What is the problem? It's very expensive and we don't know the price. There are no price signals. Why is the price so high? It's a combination of things. Again, I'm not going to give you one answer for everything, but this is right from the manual 2020, the Healthcare Connecting the Dots manual. The payment reimbursement systems have created an unfriendly consumer marketplace, and this is the key thing, that relies on incomprehensible maze of billing codes resulting in unimaginable price complexity. If you've ever tried to price a number of healthcare services or even figure out an explanation of benefits after the fact, you know this is true. And so what we have found, this is why we call it connecting the dots. Today, we have a very unfriendly healthcare system. We have, in our book, we talk about 5 dots. The providers, by the way, I don't like that term when I talk about physicians, but we're lumping them all together. The payers, the insurance companies, the government that regulates, and then offset are the patients and the employers who are the ones who are going to pay the bills, and their interests are not at the top of the list. Their interests fall subservient to the other parties. What we're trying to do is realign the dots and create a market-friendly system where patients actually are in control. This is our common goal. I know it's what Jeff and Charles have been talking about, and many of us have for a long time. So let's take a look a little bit at what a patient-friendly marketplace would look like, where patients are driving the change and where we reduce the cost of healthcare, because we have to do that. If we don't do that, we are going to head down a hill from which we cannot get back up again. To reduce the cost by increasing awareness and competition, by creating new types of health plans, as you guys have done. And we're going to talk about one in particular, not the answer, just an answer, and change government's role to better define it and to confine it to certain areas, and then give us more information about price and quality instead of relying on a government website or some commercial website. We actually talk about individual private driven information websites. And the most important thing, simplified price transparency, a way to understand the price in a more simple fashion. We've introduced a term we call the hidden tax. Some of you are going to take issue with this because you're literalists, so you have to give us a little grace and mercy on this. You'll understand why we do this in a moment. So we went to Merriam-Webster. We said, what is a tax? Well, a tax is usually a charge of money imposed by authority on persons or property for public purposes. We can disagree on the value of public purposes, well, we do often, but that's how we define a tax. And a second definition is a sum of money levied on members of an organization to defray expenses. And so we're talking about, in a sense, even though it's not a tax you pay to a government, the amount of money collected by a private insurance company that helps to offset the low reimbursements of Medicaid and Medicare. So we talk about the hidden tax as the amount of money that you pay when you buy private health care and private health insurance to offset the cost, the low reimbursement cost of Medicare and Medicaid. That's the difference in the dollar amount paid for healthcare services by privately insured individuals compared to the Medicare allowable reimbursement amount. Now, let me be very, very clear. We are not advocating a Medicare price or Medicare reimbursement for everybody in the private sector. We're talking about it in terms of demonstrating how we pay for health care. And here are some examples as reported by various sources. The U.S. Congressional Budget Office, this is old data, said that there's an 89% hidden tax. Now, they didn't use the term hidden tax. That's our usage, our verbiage. Actually, what they said is 189% of Medicare. The RAND Foundation has done some great studies in which they went in and they studied the spread from Medicare to private insurance payments in a number of hospitals, and they're expanding this study. We're looking for, hopefully in 2020, an updated study. Well, they found 193% hidden tax on hospital outpatient services. So this means for $100 of hospital services in Medicare, you're actually paying $293 if you have private health insurance. And they found an average on hospital services of 141%. Minnesota's community measurement, which does a lot of price comparison, found an 87% difference between Medicare and the average price of services in the state. But on some things, they found far greater margins. I'm going to show you that in a second. In the manual Healthcare 2020, we analyzed these tables that we told you about where they have to disclose their billed rate, their average insurance reimbursement rate, the Medicare rate, and the Medicaid rate. And we found an average of 101%. So the clinics in Minnesota were charging on average 201% of Medicare for clinical services. Minnesota measurements, however, found some deviance in price. And this is part of the problem with healthcare pricing, is this complexity. More than 1,250% difference between one provider and another provider for the same thing, markup. If Medicare pays providers then for $100 for a doctor visit. At an 89% hidden tax, the private insurance will pay $189. This is what we're saying and why we call it a tax. 141% hidden tax means private insurance pays $241. And Minnesota's primary care clinic services at 100% average tax means insurance pays $201. And at 190%, 193%, which is the outpatient rate that RAND supported or RAND reported, that means that private insurance is paying $293 for the same service. This is, I always hesitate to use a lot of numbers in these presentations, but I don't know any other way to help it. So I'm going to give you one more example, and that's from, again, using the RAND and the CBO numbers. If you have a $10,000 Medicare reimbursable hospital procedure, it means that with the CBO 89% tax, the private insured person is going to pay $18,900. The private insured person on the RAND study would pay $24,100 for that same procedure that Medicare gets $10,000 or reimburses at $10,000. And these numbers, you can multiply them, you can do all kinds of examples. But here's the whole point of this. If you have to pay, or your insurance pays $241,000 for a procedure that Medicare pays $100,000 for, a good portion of that money is used to offset the low reimbursements of Medicare. And that's why we call it a hidden tax. We believe that this offsetting amount is a good reason why family health care premiums are so high, along with a lot of other factors. Now, we talk about the tax rate. We just talked about 193% and all these numbers. So nobody knows what that is. It's not disclosed anywhere. And this is part of our point of what we think needs to be done. So you know about payroll taxes. You know what the tax rate is. It's totally disclosed to you. Sales taxes, by the way, we found a range from as little as 0, but where there are sales taxes from 1.43% all the way up. This is statewide, not local, 9.47. And those are disclosed to us. Income taxes, you know, they're a rate, and those are disclosed to us. And property taxes range from a 0.27 in the states where they're really low to 2.47. Actually, I kind of argued with that number because I think they're higher in Minnesota on commercial. But those are also disclosed. And then there's the federal gas tax at 18.4 cents. States have their own gas tax, but that's sort of disclosed. People aren't really aware, I don't think, when they buy a gallon of gas, how much of it goes to taxes. In fact, the largest portion, the profit, is far less than the tax rate. So private healthcare's hidden tax, we find, on average, with all of our analysis, ranges from 30 to 300%. And it's hidden behind a complex reimbursement system that makes price transparency and price points very difficult to understand. So we asked the question, who knows about the hidden tax? Well, providers know about the hidden tax because they do the billing for their own firms, and payers definitely know about it because they're the ones who are assigning the billed rates to the codes and matching them up. The government absolutely knows about it because they're the ones who have designed the complex system and they set the prices for Medicare. The ones who don't know about it are the patients and the employers, and they're the ones who pay the bills. So they're paying this huge markup, if you will, without any knowledge. And so we've created, if you will, a very, very unfriendly marketplace, perhaps the most unfriendly marketplace of anything that we buy or sell is healthcare. We have an open-ended promise to pay. When we go check in at the clinic or we check in at the hospital, wherever it is, we sign a statement that essentially says we will pay anything, whatever you ask at the end. We're just going to pay it. Don't tell us. We don't want to know. Well, actually, we should know. We would like to know. But that's the way it works. Imagine if you bought a car that way or something, and you went and you just said, I'll take that car, and 30 days later you got a bill for $100,000 for a Kia. I mean, you'd go nuts. But we don't buy stuff that way. Even with HSAs and high deductible health plans, they're very difficult to use when you don't have any price points, any ability to shop based on price, because the prices aren't there, or the ones that are so complicated that you can't understand them. We know that private pay patients have to pay a lot more than public patients pay. We know that there's tremendous price disparity without transparency. In that Minnesota measurement study, they found a hip surgery, the difference in price for the exact same procedure was $6,666 to $47,000 and some dollars for the same procedure in the same town here in the Twin Cities. And you have a lot of limits on choice. You don't have the freedom to go to any doctor that you want to go to or any hospital you want to go to. You are limited by the network that you are assigned to when you buy your health plan, or the network you choose. So you don't have the freedom that you'd really like to have. And then there's surprise bills when, surprise, surprise, you weren't really in network and you just got a huge bill you never expected. Or you went in unconscious and came out of a hospital in which you didn't have network coverage, and you get hit with a huge bill. My partner, Greg DiTillo, worked on a case where this fellow went in with a reference-based price system health plan into a St. Cloud area medical facility, had heart surgery. The billing was $95,000, and his insurance would cover about $45,000 at the reference-based price that they had agreed on. And he couldn't do anything to move that guy off. They tried repricing. He tried threatening him. He recorded it. So we actually played it for Star Tribune reporter, and his jaw dropped. He can't believe it that they won't negotiate a price at this hospital. Well, they got a huge surprise bill. And then the incomprehensible price complexity, if I haven't mentioned that enough. Keys are transparency is key to making a marketplace system. We need information, we need patient empowerment, and it's the idea behind HSAs and high deductible health plans that we can shop better if we can actually get the price, but you gotta have price transparency. So in a patient-friendly marketplace, and again, I'm repeating, I wanna make sure you understand, I understand this is a very complex thing. This is a step, we believe, in the right direction, and that's to disclose the hidden tax. And we call this the Medicare percent. The Medicare percent is the spread between what Medicare would pay if they were paying and what the health plan is paying, or what the provider will accept as full payment. Actually, that's the key thing, what the provider will accept as full payment. This is what Charles had seen when we were going through the slides the other day. We used this in the manual. So now instead of gas stations, you have these 4 clinics on the corner, and you have a Medicare percent that's been disclosed now. We actually have a bill introduced in the Minnesota legislature that will require this disclosure. And so you get on the phone and you say, what percent of Medicare do you accept as payment in full? And we find 4 clinics in the town, all within driving distance. And the Southwest Clinic says, we'll accept 125%. We actually found one in Medelia, Minnesota, a little town in Minnesota that's 109%. And by the way, Mayo Clinic's at 274%, just in case you want to know. The Southeast Clinic in town is at 150%. The Northwest Clinic is at 200%, and the Northeast Clinic is at 300%. Now the patient who knows what the percentage is can ask the questions. Why do you charge more? Why do you charge less? Is it worth it for me to drive across town to the Northwest Clinic, or can I go to the Southeast Clinic? Will I be happy because I know I'll be paying less? So here's an example. Let's say a preventive visit for a 40-year-old. We actually took this off the Medicare chart. Medicare pays $153 just to see the dynamic. At 125% of Medicare, that's $191. At 150% of Medicare, it's $229 for the same exam, and $306 at the Northwest Clinic, and $459 at the Northeast Clinic. So it really does make a difference what that percentage is that these clinics are willing to accept as full payment. So we think that it is a concept of pricing that will be useful for all kinds of consumer-friendly models. We talk about high deductible health plans. We talk about health savings accounts, health reimbursement arrangements, healthcare cost sharing, direct pay care, reference-based pricing health insurance, which I'm going to spend just a moment on. All of these require price transparency. The Medicare percent disclosure will aid in all of these cases in making us better shoppers. It creates a consumer-friendly healthcare marketplace with price transparency that leverages increased payer and provider competition, allows employers to shop. It limits annual, this is reference-based pricing now. I'm sorry, I've got so much going on in my head. Limits annual premium growth to the change in the consumer price index, because if they have to disclose their Medicare percent, then Medicare, which only goes up a little bit at a time, if that percent stays the same, their increases annually on the cost side are not very great. It allows HSAs and HDHPs to function, and it breaks up the need to choose and use networks. And actually, when we first wrote the manual, one of the things we talked a lot about was doing away with networks altogether, that these types of health plans could make that happen. We decided that we're really more about choice, and that people should have the opportunity to choose a network plan if they want, or a prepaid plan if they want, or if they want to buy health sharing coverage or whatever. Let's let people decide, but let's give them the Medicare percent so they know what they're paying. It does challenge insurance company monopolies as well. Now we're talking about patients meeting with a doctor and saying, what's your Medicare percent rate? How much of Medicare will you accept as full payment? This works very well. In fact, we think it is necessary for reference-based pricing health insurance models to work in the best way. We know that there are reference-based price models out there where the carriers are going in and negotiating balanced bills, and that's okay. That's a step toward nirvana as far as we're concerned. Reference-based pricing models where the health plan will pay a percent of Medicare, and it's known ahead of time. In my dream world, you could buy 140% of Medicare, 150, 160, maybe 200% of whatever you want to spend on premium. I know that's not necessarily available yet, maybe someday, but it reduces administrative time on the provider and payer time part of this calculation. It does allow for practice independence, for doctors to be able to decide if they want to get out of networks and just begin accepting a percent of Medicare as full payment. I mean, it's a tremendous value to them if they could go back into independent practice, at least for some of them. We know a lot of those conservatives who would like to be able to do that. And it puts patients in charge of judging quality and price and perceived value with more information coming from private health information exchanges. And this results from full price transparency and disclosure of insurance coverage, whether in or out of network. And this is another bill that we've sponsored here in Minnesota that actually will require a provider to tell you whether you are eligible, you have an eligible expense, and if you're in or out of network. So then you are fully informed. Being shopped means producing better patient value. If the patient is able to decide between one provider and another provider gives the patient better value, and it allows providers to negotiate a single Medicare percent for all contracted specialists. Let me touch on that just for a moment. Again, I got so much data in my head. You know that it's common when a person goes in for surgery, they have an anesthesiologist or radiologist whose bills are 1,000% or 1,500% of Medicare. Greg had one client who Medicare would have reimbursed at a little over $1,000, and the anesthesiologist was at $8,400 and wouldn't negotiate and threatened to take him to court and so forth. So I've done kind of a really quick sloppy overview of what the ideas are in the manual Healthcare 2020, but suffice it to say, what we're trying to do is develop a single price reference, price transparency reference in the Medicare percent, require that it be disclosed by providers so the patient will know, and the patient can compare those price transparent Medicare percents from provider to provider and make a more informed choice. And so, fellas, I'm going to drop back onto the screen with you all, and let's have kind of a wide-ranging discussion, if you will, about whatever's come to mind.
Okay.
Yeah, willing to go anywhere with you.
Fantastic. That was really very good. It did a great job of really laying it out in a way that, you know, it's not often that clarified the way, because like you said, even the explanation of what's going on is complex, and you did a nice job really making it much more simplistic. And we definitely have some hands up here. So let's kick it off. I see, Paul, you've got your hand up.
Oh, Paul.
Yeah, hi. Dave, that was a great presentation. I appreciate all the information. Yeah, I just wanted to say we understand the merits of what you're referring to with the transparency. From a psychological, motivational standpoint, if you're a provider, obviously you want to make as much money as you can, as you can get away with, basically, right?
Right.
What are there any repercussions from their standpoint in terms of who they will accept or what networks, et cetera?
Well, yeah, there is, of course. I understand here it's common that most providers are really in just about every network, and there's 30, 40, 50 different networks in a state, and even with the same carrier, there's several different networks, and they're very good at hiding their prices. It's very hard to get a price. In fact, in some cases, they've had gag orders. We did get that included in the bill, by the way, that they have to give you their price. And so, yeah, there's a lot of pushback. We believe there are providers out there who would like to be free from those networks and be able to compete in the marketplace. It's not our intention to force anybody to price set. What it is our intention to force them to disclose their prices. And to get out from behind the veil. We don't think that there's any negative in terms of the patient and in terms of the employers who pay for so much of our health insurance. And that's who we're concerned about. Yes, definitely pushback from providers and payers and government that likes to regulate everything.
Yeah, and just to follow up on that, thank you. I was thinking as well, I agree. I mean, a free market should operate as a free market in terms of supply and demand, for example. But on the other hand, let's say you're in a rural area and there's only so much access. Mm-hmm. Is that kind of a counter argument, would you say?
Well, it would be if the experience didn't show it to be different. We have done analysis of dozens of these price transparent charts. It's pretty interesting to see how the rural areas, we would call them greater Minnesota here, how they actually, their Medicare percentages are lower than those as particular in southeastern Minnesota where Mayo Clinic dominates. So it seems to be more of a thing where major clinic dominates. Even in, out in the state, it's not, you can't say rural about St. Cloud, Minnesota anymore. It's a pretty big town, but go up to Duluth and the prices, the Medicare percentages are less. And so I don't think that there's a blanket answer on that. Some areas are less and some are not. And the point is, they ought to know what everybody's charging.
Thank you.
Very good. Charles, I see you got your hand up.
I do. Jeff, thanks. And Dave, fantastic presentation. Before my question, I'll just remark that for the doctors, that you're right, do want independence. So many of them accepted employment in hospitals to escape the hassle from regulations or third-party interference, only to find out that they're no more happy in the hospital than they were on their own. So now so many doctors want to step back into independence, and they're a bit nervous about losing the comfort of being an employee or being reliant on Blue Cross or Medicare. But next week, this same day, same time, our doctor partner, Dr. Tom Davis, will present our solution that builds pretty much exactly on your presentation. I've taken some good notes here. We facilitate the listing by doctors of their prices. By doing so, we do away with networks that you are correct, handcuff choices, and expose folks to surprise billing. And we do rely on HSAs for the individuals and small groups and HRAs for the bigger groups. And we do incorporate a version of reference-based pricing with TPAs or however our sharing company negotiates with the hospital on the back end. So you're exactly right that reference-based pricing is a growing model. And Jeff and I have complained for years about the lack of a real market to unleash our freshly empowered patients on. And so your admonition, I think, will work. Just ask around, what percent of Medicare will you accept for full payment? That is a great question. And you can comment on all I said. My question, though, is the deeper you get into healthcare, you hear this rumor that the Medicare tax that private insurers endure, and which manifests in your outrageous premiums, whether individual or employer, it's not something a lot of those Blue Cross type companies mind. And maybe you know something about how private insurers charge customers, and maybe they don't mind the higher prices so much charged by the hospitals. Do you know much about that controversial topic, how the BUCAs are kind of insulated from this crazy pricing because of a sort of an oligopoly? Am I making any sense here in this question, Dave?
Well, I think there were about 5 questions there. So one of the pieces of data in the book is the top 5 health insurers in the country have 82% of the employer coverage, which probably tells you something. And they're able to retain 15% of premium for admin cost and 20% on fully insured. And so we're, which is, mainly small group and individual. There are some larger groups that are fully insured, but our contention is that there's absolutely no motivation whatsoever for the insurance company to reduce prices, because if they reduce price, they reduce premium. And if they reduce premium, they get to keep less. And so they have a negative incentive, if you will, although a good part of what they're trying to do theoretically is keep the price down and keep use down. They're contrary motivations, and I don't think they're certainly working to reduce the price. If they were, you would see the trend go in the other direction. It would be going down, not up. We think that the private insurance industry is at a crossroads, though, because at $20,576, that was last year, and we know it's going up, and we know it's much higher for so many people. there's a lot of people that are at the end and they're saying, I can't do this anymore. And, you know, government fix it for us. So we know that's not the answer, especially in the United States. It's not the answer. But we're really concerned that we're going to get to that point. And so the insurance company's self-interest is, let's get this straightened out somehow. Let's find a better answer than marching down the road to Medicare for all. We're going to get there eventually if they don't find an answer. Another thing I would like to just address for a minute, you know, I work with a guy named Greg Detillo. He's been doing this business for 45 years. He's a smart guy. He's a thinker. And Greg and I get together and we just beat on each other and we learn and learn and learn. And we learn, as Charlie Tremendous Jones would say, we're learning that the more we learn that we need to be learning. And so we made a lot of assumptions about how price transparency, how this Minnesota law would make it so much easier for people to shop. And so we had all these charts, you know, dozens of these charts that I downloaded, and I'm comparing side to side. And you know what? The top 25 procedures in Madelia compared to the top 25 in Foley, Minnesota aren't the same. And so then you try to line them up, you know, side by side to see whose price really is the best price. And it's really complicated. So the Medicare percent is much simpler. We analyze those charts, we come up with an average price, and we say, well, you're at 187%. Why don't you just tell us that? You know, because that clinic down the street's at 224%. Maybe you'd get more patients if you were charging less, you know, or maybe you could charge more. Well, we don't want that, but so I don't know. You asked a lot of questions and I gave.
You know, and that was a good response. And one thing to comment about that Medicare thing is the fact that, you know, matter whether like you Medicare or not or whatever, but at least it's a fixed number somewhere that you can gauge other numbers by.
Yeah.
So it's almost like it's a compass, even if it's a meaningless number and all the rest of it, but at least it's some metric that I can at least compare somebody against somebody else. And like you said, it forces, in a backhanded way, transparency onto those players that are not happy to give all their numbers away. Because you certainly don't have any complaints with the guy that can't wait to be like Oklahoma Surgery Center. They can't wait to tell you how cheap their number is. Yeah. They're not trying to hide a thing.
Exactly.
So it's definitely the situation for sure. Right? I see a guy, Kishore's got his hand up over here, waiting patiently. You have to unmute yourself, I would think. I'll unmute you again. Try now.
All right, so I unmuted.
Yes.
Right. Sorry. Thanks for letting me ask this question. So my question is, you know, at the end of the day, what you're looking at is price distortion, and Medicare is principally responsible for it. So if you have to get rid of it, if you have to get transparency, you have to get rid of Medicare. Or, you know, I don't see an alternative to that, because as long as Medicare is there, it has a need to subsidize services. It can't improve efficiencies. So the price keeps going up. And I don't see a constituency calling for end to Medicare or an alternative way to serve the needs of the elderly.
Yeah, well, I really appreciate that as a member of the elder generation now. I'm very aware of, and having studied it and participated in it for a few years now. This is one of those, we have what we have. It's not necessarily what we want, but we have a system called Medicare that's there, and it's not something that we're going to get rid of, at least overnight, if we ever can. So it's like I'm reconciling myself to reality that we have Medicare, and it is a reference price for a huge percentage of medical procedures, medical and surgical procedures, and durable medical equipment and pharmaceuticals, and on and on and on. I mean, there are Medicare prices for just about everything. Do you know there's even Medicare price for delivering babies, for maternity, which is kind of odd, but then there's some people who are on it, and they got to have prices. So I love this word ubiquitous. It's a wonderful word. The Medicare price is ubiquitous. It's everywhere. When I first introduced this, I'm on the board of the Minnesota Physician Patient Alliance, and these are the old conservative doctors like those at the Association of American Physicians and Surgeons, who are really conservative. They tend to be libertarian types. And they heard me say the word Medicare, and they kind of went nuts, you know. I said, no, it's not pricing at Medicare at all. What it's saying is you can price at any price you want, but you're going to price at a percent above Medicare, because that's the way most commercial insurance policies actually reimburse, at a percentage above Medicare. They don't set a price for every little detailed thing. We're kind of working with the system that's there and making it more transparent. That's the point.
Actually, the way you can also get rid of it too is to do stuff like that. So that's needed regardless. David, I see you got your hand up.
Dave, is there enough cash basis healthcare out there beyond direct primary care to make price comparisons on specific procedures like colonoscopies, hip and knee replacements, appendectomies, and so forth? And if not, what is holding back widespread cash basis procedures?
Boy, I think that there's a general understanding in the public that you don't pay cash for things, that you have insurance do that for you, and you know, you're their servant or they're your servant. I guess it's a mutual thing, and someone else pays the bill. I think that is probably the big hindrance. We have many, many people who now, even with what's going on with the high prices of health insurance and then the COVID virus thing happening, enough people are getting thrown back into the private system that there may be more people interested. I think it's still, by the way, I'm on Medicare and I go to a cash practice doctor for my primary care. And I don't have to, but I do it because the guy is terrific. Saved my life already at least once, and certainly saved my quality of life. In fact, I talked to him today because I was concerned about my chest tightening up. You know what he told me? He says, you've been moving, your muscles are tight. Oh yeah, we've been moving our house. So cash practice doctors is a frightening idea for a lot of people because they never grew up with it. It's going to take a lot of education. People like Charles and Jeff and the rest of you talking to people and giving them that option, I think is a huge part of it. It's still terribly difficult to compare prices. You take, when you look at a website in Minnesota, you could almost take any health system now, certainly take a hospital system, and you can get all their prices, an entire long list of prices for everything. Try to figure it out. It's, wow. So we've got a lot of work to do. The Medicare percent gives us a way to get to that. By the way, the legislation that we've written would mandate providers to disclose their Medicare percent. They wouldn't have a choice.
That's one of the advantages, like we said before, as a barometer. It's like a shorthand. So somebody has to read that whole long list. They just can look at that one number and know what's going on.
That's the idea.
Yeah, and it just completely obviates the need for that list, as it were. And they can make any list they want. It doesn't really matter. I'm going to really know what the real price is in the end, at least with that metric.
So if you have a reference-based pricing health plan that pays, there's a new one here. I was talking with the agent the other day, 130% or 150% of Medicare. I think, by the way, there's going to have to be at least two numbers, one for physicians and one for hospitals, but you guys might know more about that. Anyway, to be able to know when you go to Regents Hospital in St. Paul that they're at 230%, and you go to another hospital, maybe North Minneapolis, and they're at 180%, and you've got a 150% plan. What are you going to do? you know, and these are the things that they're still needing a lot of development. But this is why we got involved in it, because we got really interested in the reference-based pricing health plan idea.
Well, you know, the other thing too, Dave, you almost have to look back as a layperson. Let's treat all of us in that regard, and look to you. You know, you've been doing this such a long time. Look where it led you. You know, it led you to these conclusions and this reality, because you've looked at it every other which way. I mean, I've read some of the stuff you've written for sure, and that is a great book, that Passion for Patients. But, you know, this kind of becomes like, what's the one way we can live with what we got? Because, of course, everyone fancifully would like to get rid of stuff, and maybe one day it is possible. And we created it, we can certainly get rid of it. But how are you going to even figure out how to get there? You first got to show that the thing's a ripoff. And so you might as well use their own numbers against them, but it allows the consumers to shop. So at least, like you said, if I'm going to get 150, I can find a doctor that it's at that or less. And if it's over, then I know I personally got to pay a couple grand extra, but maybe it's worth it to me to spend that. So that it's still, now the thing's working. Even if nothing really changed, at least everybody suddenly understands what the heck is happening to them, which is such a shame in terms of everything else you do, like your gas station thing. I don't suddenly get surprised when I'm pulling out of the gas station where they hit me with another buck on the way out just to leave the parking lot. You know, I mean, and that's almost what you're describing. My favorite, Lynn, I've told this before, but it's always a great to revisit it, is there was a great episode of The Simpsons where Marge is in the hospital and suddenly and the family's all crowded around the bed, you know, keeping a vigil. And the doctor runs in and says, "Hey, you're going to get to go home today." And she goes, "Oh, fantastic. Am I cured?" And he goes, "Well, according to your insurance company, you are."
Yeah, right.
And it was such a great line in that little cartoon. Charles, I see you got your hand up again.
Sure. As we close the hour here, Jeff, maybe you can show the Passion for Patients.
Yeah, let's bring that up.
Dave's website.
Sure,
and,
absolutely.
Dave, you're going to leave us with a recommendation on buying that book and what readers will find in it.
Yeah, well, actually, if you would go to the homepage again, that would be
okay.
That's what I wanted.
Let's do that.
This is a great book, and I think people ought to read it. Scroll down, and the one on the left. Now click on the manual, if you will. There you go. Let's get that one up. This is the one that we released in January, and it's inexpensive, $13.50. In fact, I had to argue with Greg because he wanted to give it away to everybody. I shouldn't tell you that, right? It's just that important. What's that? Oh, I'm going to buy 100. Thank you. Why did you do that? Actually, I have discounts for people who want to buy them by the case. So this is so jam full of good stuff. It's just, it's wonderful. And like everything we read, it's very readable. Passion for Patients is a wonderful, wonderful book about my friend Dr. Lee Beecher's psychiatric practice and how vitally important it is to have a doctor-patient relationship, and not just with a psychiatrist and a patient, but with all doctors who actually touch patients. And it's such an important idea. More and more people need to read that.
It was a really great book. It really made you hit the emotions of the reality of healthcare. We all get buried in the numbers and insurance and all the rest of it, but in the end, it's two people getting together.
Yeah,
almost 100% of the time when you kind of get to the rubber hitting the road. Any other particular one you want to showcase or mention that's worth kind of? Well, I tell you, I enjoyed this other one, Why Healthcare Costs So Much. That was a great one.
Yeah, we did tens of thousands of those.
That was a great one.
And Caged Bird. Well, now we get into the biography. So
see, here's that one we were referring to before, that Common Sense Medicine one.
Death by Design is a terrific book, but it has nothing to do with healthcare. It has to do with a murderer.
Well, for anybody that's ready to get a divergence from reality altogether. So there you go. Well, that was really a great day today, Dave. I really appreciated that. Super having you here with us today. And we'll certainly continue to reconvene as time moves forward and watch how we move this needle. So thanks for today.
Well, my pleasure to be with you.